Good afternoon, and thank you for joining us. My name is Liz Arrington. I'm a Director of Development at the OHSU Foundation. On behalf of the Foundation, we are honored to present today's discussion, Compassionate Communication During COVID-19, featuring leaders from the OHSU Center for Ethics in Healthcare. I want to invite you to listen in on a conversation recorded earlier about the many ways the Center for Ethics faculty are elevating compassionate communication skills during this time of crisis. Compassionate communication is so much more than just vocabulary or tone of voice. It is about truly seeing the patient as a person and not just the virus or a disease. It is about holistically supporting their wishes. This ensures that healthcare is more compassionate, more respectful, and more empowering. Before we begin our conversation with these incredible leaders, I'm going to quickly go through some housekeeping items about how you can engage with us. We will be using the chat function, which you can see to the right of your screen. To participate in the chat, simply log in via your Facebook or Vimeo account, and if you don't have that, select Chat as a Guest, which should be found as a blue link. And if you need any assistance at any time during our presentation, please email us. We will be putting our email in the chat feature for your reference. Please note that this presentation will be recorded and made available for later viewing. We will email everyone a link to where it will be on our OHSU Foundation website. And with that, it is my very great pleasure to introduce Amanda Ashley, Associate Director at the OHSU Center for Ethics in Healthcare.
I'd like to welcome everyone to this rare opportunity to go behind the scenes and really understand more about what's happening in the world of COVID, how it's impacting our healthcare system, and how the Center for Ethics is responding to these challenges. Dr. Susan Toll and I have had many opportunities for discussion about these topics, and we'd like to invite you to sit in as we talk through now some of the issues that are most apparent for us as we manage the unfolding pandemic. Susan, when the world of healthcare changes as rapidly as it's done in the last several months in response to the COVID pandemic, or if it's an earthquake or a hurricane or some other natural disaster, how on earth do you begin to respond to these extraordinary demands?
The first thing is pandemics are different from other disasters. They have special things that make them harder than floods and earthquakes. First, floods and earthquakes are in one place, and other places can bring supplies and people and help. This pandemic is all over the world, and everybody needs masks, and everybody needs healthcare professionals. Some more than others in spikes and peaks, but everybody has needs. When we send healthcare professionals to a disaster, they go for 2 weeks, and the Red Cross pulls them out and rotates them out because the amount of sadness and pain and stress is so great that they do better if they don't stay in this intense crisis too long. The pandemic is going on and on and on, and our healthcare professionals are showing the way. We need to find ways to support every one of our healthcare professionals in dealing with new ways of coping that lead us to support one another in ways we didn't used to do. Because we were always the caregivers. We didn't need any help.
So the center has a long history of responding to the challenges in healthcare, which have been many. And no doubt you have learned a huge amount from this history and from all the experience that you've had. And I'm wondering how you can apply some of that to this situation.
Fortunately, we have had 31 years of building programs, of partnering with others and building things, of leading and of consulting on very thorny issues. We have led the way and built the Pulse program from the ground up, and it's been copied by all the other states and by many countries of the world. We are the very first to test medical students on their communication skills, make it a graduation requirement, and roll out new ways of teaching about communication skills that are becoming a part of our normal before the pandemic. We can build on this because partnering and innovation are absolutely what is needed in the pandemic. That all of this trained us to have enough skills and enough foundation to pivot that first week where it became clear we were going to have a pandemic and begin launching our webinars, begin doing new innovations because we were nimble and ready.
And what are the particular challenges that you see emerging from the pandemic situation?
Well, there are a lot of big challenges. One of them is the whole issue that we have focused so much on the physical that we have forgotten the whole person. That there is a unique individual struggling with what is happening, ill, maybe anxious, maybe fearful. A second thing is that we have the whole issue of trust, of fairness. The pandemic has showcased tremendous inequities. And last, it has showcased that our work in compassion is needed more than ever.
So, Susan, you mentioned, I'm going to go out of order in terms of the things that you listed as the main challenges, because I think the one that stands out for any of us who have been going through this time together is this issue of fairness, justice, trustworthiness. When in the early days of the pandemic, if you weren't a Hollywood movie star or a famous athlete, you didn't get a test. There was no test to be found. And similarly, we were told not to wear masks, and we didn't need them. Well, it turned out because there weren't enough. And now we're being told, well, yes, you must wear a mask because there happened to be enough. How do we decipher this information?
Well, you are still right about the testing, for example, that while there is a lot more testing, and sick people in the hospital can get testing and testing fast, patients in nursing homes can't always get all of the testing that's needed to stop the hotspots, or in group homes for those with developmental disabilities. People in meat packing plants and other places are not being screened enough on a regular basis. Persons of color clearly have disproportionate burden with this disease, but so do those with developmental disabilities who've gotten much less attention in being sure that there are adequate resources, being sure that they have adequate support and care, as well as simply getting enough masks into their group homes.
So what can be done about that? How can that become more equitable? Because we've seen so much that hasn't been.
Well, the first thing is we put a spotlight on it and we tell the truth. We gather data that shows us who is getting sick and who is dying, and we're honest about where those outbreaks are. Because you can't put resources where they belong without honesty about what's going on. And healthcare needs to be more trustworthy at every step of the way. If I tell you I'm calling you on Friday afternoon with a lab result, I need to call you. If I don't have the result back, I need to call you and tell you I don't have it. We need to keep our promises, and we need to advocate and fight for all of the discrimination that has adversely affected health outcomes.
We've heard so much about shortages of masks, yes, and tests, but also ventilators, ICU beds, if we get another surge. And I wonder how the healthcare system even begins to decide who gets them and who doesn't if there aren't enough to go around.
We hope it doesn't happen, but there are some lessons we've learned from things like how do we make decisions about who gets a liver transplant when there aren't enough. And those decisions are made by who will survive, particularly who is likely to survive till hospital discharge. It does not make sense for us to give a ventilator to someone who has a very low chance of getting out of the hospital when someone who has a much better chance could use it.
Earlier, I had the chance to talk with Dr. Tyler Tate. Dr. Tate is a pediatric palliative care physician, and he's also the director of professionalism and comfort care, supported by the Miles J. Edwards Chair. So I'd like to welcome Dr. Tate, who has been in the front lines of the pandemic, caring for patients and their families during these incredible stressful times. And so, Tyler, the first thing I'd like to ask is, how can you help us understand the experience that you and other healthcare professionals have been having in this very stressful world of a hospital in which COVID is a factor?
Just 2 months ago, a little girl with a rare genetic syndrome that caused her to have uncontrollable seizures, pretty profound cognitive impairment and intellectual disability. And the family was Spanish speaking, so which, with no other problems already is a difficulty in trying to provide good, thoughtful, and compassionate communication. And this little girl developed respiratory distress, likely due to some virus. Could it be COVID-19? No one knew to begin with. Was admitted and ultimately got sent up into the pediatric ICU, which, for those of you who don't know, is an incredibly terrifying place with, especially if you don't have experience with healthcare, bells and whistles and machines and people running around trying to address code situations. And this little girl was initially stuck by herself because of worries that parents might have COVID. No one could be with her. So this 2-year-old who, for most of her life, and certainly any time she'd been admitted to the hospital, was able to have her parents there who knew that, when she, for instance, I remember kind of, a curve of the mouth, a certain kind of smile or grimace means I'm hungry or I need a diaper change. But the nurses didn't know this. And so the parents were so anxious about sort of being split apart from their daughter, who was dealing with horrible respiratory distress, ultimately got a breathing tube, was having to have massive amounts of sedation. Healthcare providers, we were doing our best to facilitate good compassionate communication, good thoughtful calling of the parents, but it was really difficult, and everyone felt like they were being shortchanged and shortchanging the parent or the patient. And this was just one example among many of the ways that patients, families, and healthcare providers were, it felt like, put into incredibly tough and almost insurmountable situations to provide good and compassionate care. So it's been unlike anything I've ever experienced, incredibly challenging.
You've talked too, Susan, about the incredible burden of isolation and anxiety for people who may have COVID or who worry that they'll get it. And I wonder if you could talk more about this and how we can take care of people who are dealing with these very profound issues.
Well, the first thing is we have to be better listeners. We have to shift much more from the focus so purely on the physical to the fact people do need visitors, and thank goodness the visitor policy has changed. It may change further over time, but the fact that if you couldn't speak for yourself, you didn't have someone with you, if your loved one got a stroke and couldn't speak, you couldn't be there, that is unthinkable in the anguish it causes patients and families, in the anguish it causes our healthcare professionals.
Susan, I have an 85-year-old friend. Many of us know people who are 85. Some of us might even be 85. And my friend is really quite terrified right now. She's seen so many things in the media that have frightened her. And I'm wondering what your advice would be to me? What can I say to her to help her find more calm, more confidence during this pandemic? And then what can healthcare professionals say to her that will be helpful?
The first thing is seeing TV. You see emergency departments, you see intensive care units, you hear a lot about how sick people are, you hear a lot about people not surviving. And when we first got testing, we were only testing the sickest people. So it looked like most people died. The bottom line is, most people who get COVID do not die. We're learning that 40% of people hardly get sick or don't get sick at all. Now that we have more testing, we're better understanding that there is a whole pattern for this disease, and not everyone gets as sick as what you see on TV. This is a bad disease, it's serious, but if we focus on the bad numbers, the bad outcomes, and what you want if you get really sick, it frightens people and it makes it hard to have a conversation. We're trying to teach healthcare professionals to talk to your friend in a way that says, what matters most to you if you were to get very sick? To talk about values, to talk about what people care about, instead of ventilators and intensive care units. After people talk about their values, then we can talk about how does that fit with treatments available. But people need help with the new language to talk to their families about what matters most.
Well, the center is known as the developer of the PULSED program, the Portable Orders for Life-Sustaining Treatment, which turns people's wishes into medical orders. And I think this is a time when many people might be wondering, is this the time when I should have a pulse in the midst of this pandemic?
If you're ready to say, no, I don't want to go to the hospital, or I wouldn't want intensive care, or I wouldn't want CPR, then you're a candidate for pulse. If you're saying, if I got sicker, there are things I would not want, you need an advance directive and no pulse. If you're saying no to things, you need an advance directive, which appoints someone, shares your philosophy, builds on a conversation, and you need a pulse form so that you turn those philosophical statements into medical orders that can be followed by emergency personnel in a crisis.
And by that you mean those orders will be followed now, regardless of any circumstances. They apply now.
If you collapse, emergency medical personnel will look at the pulse form and do what it says. Whether you had a stroke, whether you have COVID, they will do or not do CPR based on those orders. But it is not a disease-specific document. It is about the treatments you would want, no matter what else might be wrong.
So for a healthy person, even if they are getting up in years a little bit, are you saying an advance directive is the appropriate document?
I am saying that all adults should have an advance directive, sick or not, so that we know what you want and who we should speak to. And that it's a really good time in the face of a very serious pandemic to step up and get this done, because unfortunately it could be needed.
We have a question here about how the center deals with financial incentives.
Since the center's very beginning, we have felt very strongly that funds from industry sources could create even the appearance of a conflict of interest, that we were not speaking for and advocating for patients. So we do not take money from pharma. We do not take money from device makers. We do not take money from insurance companies. We do not take money from healthcare industry sources. And that allows us to be more trustworthy, more outspoken about issues as we advocate for patients. For example, polls. It is possible that setting limits could be of interest to someone who might benefit from having people do so. The Center for Ethics doesn't make any more money if you fill out a post full code, full treatment, or you set limits and want comfort measures on them. We want to maintain that integrity. And having the power of private philanthropy to give us that independent voice has been critical to our being a trusted source of advocacy.
I'd like to pivot here, Susan, to talk about the burden that this pandemic has placed on our healthcare professionals who are in the front lines at all times. And here's more of my conversation with Dr. Tate.
Just a couple days ago when I was on service and I was talking with one of the intensive care physicians who brought up this exact question. He said, as a palliative care provider, I'm realizing that we need you to help us as clinicians just as much as some of these families need you, because moral distress is the feeling that you are being prohibited from doing what is right because of structures and powers that are larger than you. And that's oftentimes what it feels like when we want parents and families to be with their loved ones, but we also feel like we can't because we're worried about spreading this virus. Compassionate communication means being compassionate, and so learning to really to work with each other and forgive each other when we offend or when we stumble. And healthcare is a team effort. Caring for patients is a team effort, and I think that here at the Center for Ethics, and I see it spreading out into the different medical wards, we want to be there for each other.
Susan, I wonder if you could give us an overview of how do we acknowledge the extraordinary strain on our healthcare teams, and how do you begin to address them in a pandemic that is likely to go on for a long time?
Well, our healthcare teams are going at this for months and months, and they do get ground down. They benefit enormously from the improvements in the visitor policy and that tremendous moral weight of things being wrong. But we have got to learn new ways of supporting one another and asking for help and reducing the stigma of needing help, because this burden is going to be hard for any of us to carry as we go forward months and months into this. Healthcare professionals have often felt like they were very much serving others, but didn't personally have needs. And bringing that bar down so that people can reach across it, support one another, and get the help they need when they really do need it.
So you're saying that the healthcare professional is a whole person too?
Absolutely. And treating healthcare professionals more holistically, patients and families more holistically, and other members of our healthcare team as true members of our team are going to get us through this.
Which brings us, I think, very naturally to a program that the Center has been working on for some time. It's well known for the educational programs that have been, in some cases, become national models. And the program in compassionate communication is sort of front and center of the Center's work right now. And I wonder if you can tell us more about that and why it's important with or without a pandemic.
We had challenges before the pandemic. We had areas that we were building the program in compassionate communication to address. We had problems giving bad news. We had problems being completely transparent in talking about a medical mistake. We had ways we could improve our skills in end-of-life care and communication. Those are still here and still with us. And now we have the other layer of the pandemic and what we need to do to improve in a whole new world.
This is a great moment to introduce a video that was produced earlier this year that shows Dr. Katie Stowers, who is a palliative care physician and the Ronald W. NATO Director of Serious Illness Education. And to watch Dr. Stowers as she leads a class through a training with a real actor portraying the role of the patient as they struggle to find the right language, the right communication skills to help the patient understand that her condition has deteriorated. So let's see that now.
We need programs to teach healthcare professionals how to have compassionate conversations with their patients, because living with a serious illness is hard, and caring for someone with a serious illness is hard.
Our job is to sit there as a human with another human and say, I support you, I hear you, I understand how really terrible this is, and just sit with them there in the moment, responding to them empathically, and hopefully we can get them ready to process and think about where we go next.
And so I can only imagine what you're going through, and part of my purpose here is to support you and anyone who's important to you as you're going through this illness. I'm starting to see that there's a disconnect between what she's been told and what she understands, and so I'm worried about her, and I'm worried about how she's going to deal with the information that I'm hoping to share with her today.
What's kind of your endpoint? Where are you hoping to get to with this?
And this is just such a difficult conversation. So, but I would like her to know that she doesn't have any more disease-directed treatments and that she's likely to die from her cancer. And that's a very different place than where she's at now.
Yeah.
Yeah. I don't know. I don't want to use the term she can't fight it anymore, because I do think there's a lot we can do for her.
Yeah.
So I don't know exactly.
Do you want to?
Yeah, I'd be happy to get some help.
Get some ideas from the group?
You could maybe say, you know, Karen, would it be okay if I share with you what worries me about what I know of your cancer now?
Would you like to try saying that to Karen?
Oh, sure, yeah. So I do have some thoughts about that. Is it okay with you if I share some of those thoughts?
Yeah, I mean, please.
Okay.
So what does that mean?
My worry, Karen, is that more treatments for you aren't going to do anything to help you feel better. In fact, I'm worried that they will make you feel worse.
I'm sad. I'm not necessarily surprised. You know, I've just been so out of it.
And it seems like that really opened up a space where she felt much more comfortable to share even more with you.
When she goes home to tell John,
Yeah.
what's the one piece you want her to remember?
Yeah, so the piece I want her to remember is that there are no more treatment options for her cancer. We will support you through this whole entire process. It doesn't end when I leave the room, and it doesn't end when you leave this hospital. Okay, this is a journey that we'll be on together.
This work has definitely affected my patient outcomes because I feel like I'm able to partner with them more. I feel like they have more trust in me, and I always cared as much as I do now, but I feel like I'm way more skilled at expressing that and letting them know how important their care is to me also. So I think it works both ways.
Everyone can do this, and everyone can get better. And what's really exciting is that people really want to. They really want to be involved and to learn.
That kind of teaching is making a difference. We have been reaching out and helping those who teach residency programs, those who teach fellowship programs, how to become instructors in these skills. And the net result is a ripple that's going out. In fact, we received a letter from colleagues at Kaiser saying that when they hire new faculty and they test them on their communication skills, they can tell if they trained at OHSU without asking.
So it's paying off, and it's really quite touching and inspiring to see in this video how very hard these professionals are having to work and how far they're willing to stretch outside their comfort zone to find the right language, to find the right level of communication in order to work compassionately and also effectively with their patient.
And what we see is that you have to practice. You can't read about this. You have to get in there in the hot seat and struggle to learn these skills. These are learned by practicing, by feedback, by practicing again.
And I'm going to guess that the actors, the trained actors who play the roles of patients, also practice and also have a high level of training. It's a difficult job.
It's a very difficult job, but when they do it well, it's so realistic. And it really forces you to see where you need to improve your skills and where you're struggling. And it teaches you the courage to try things that help you walk into areas that maybe you shade away from and not help patients and families on the difficult path they have ahead.
I think one of the things that this video really shows is the courage and the humility that it takes for healthcare professionals to be willing to learn what they need to learn to do this work. I had a chance to talk earlier with Dr. Stowers about the program in compassionate communication and why compassionate communication matters so much now more than ever.
I think many of the challenges that we were facing pre-COVID have only been further blossomed by COVID. We're now separated by our loved ones, by computer screens. We're now more anxious and more uncertain about the future. And it has made all of these challenges that we've previously been facing a little bit harder. And so I think now more than ever is the time to really dig in and try to focus on empowering physicians to have these conversations better.
Back to you, Susan. People have been staying away from doctors' offices and hospitals during this pandemic, staying away in droves. And one of the things that's been happening is more and more virtual visits, which presumably is a wonderful way to bridge this gap during the pandemic. Is this the future of medicine? And if so, how can you help clinicians adapt to this new reality?
Well, certainly things have changed profoundly. Sometimes people are staying away when they shouldn't stay away, and that's a concern in and of itself. We're also seeing that virtual visits are increasing and that sometimes they actually work well. A patient who is at very high risk if they were to get COVID can stay in a safe environment. But it takes a whole new set of skills to be able to communicate effectively, empathically over a virtual visit. And those skills are something we're teaching all of the new house officers that are coming now to our campuses. Our residents, our interns, our fellows need to be taught not only technically how to have a virtual visit, but how to do it in a way where a person feels heard, feels cared, when I can't reach out and touch them.
And have you been surprised by how well they're going in some instances?
They have been well received in some cases and received very negative reviews when that connectedness and caring doesn't happen.
So you're seeing the vital importance of the training as a way to bridge this gap.
Incredibly important, urgent, and a pressing need. And the thirst for this, the desire to be taught, is far greater than anything we would have anticipated.
What have we learned from this pandemic that will be useful to take forward? Because there have been, I'm sure, many lessons learned, and some of those will be incredibly valuable. for the future?
Well, one of the things we've learned is nimbleness. We have to pivot and deal with something new. We have to take a deep breath, whether it's virtual technology and communication, or whether it's how to create webinars instantly that meet needs. But the biggest message is we need to be kind. We need to be kind to ourselves, our colleagues, each other. I am filled with gratitude to be able to get up every morning and go, the work we are doing matters. So many people can't make a difference in this pandemic. So many people can't change the suffering or deal in any way that makes it even a little bit better. I am so grateful for those who've made it possible for the Ethics Center to do this work and to have us be able to chip away at one piece after another as either partners in the work or leaders in a new effort in communication. These are hard times, but they're also times of opportunity.
Thank you so much, Susan.
I would like to thank Dr. Toll, Dr. Tate, Dr. Stowers, and Amanda Ashley for their time and for sharing just why compassionate communication is more important than ever. We are now going to start our live Q&A with Dr. Toll, who is calling in from her office on campus at OHSU. As a reminder, if you want to participate in this live Q&A, please utilize the chat box feature. You can select to register as a guest if you do not have a Vimeo or Facebook account. Before we get into your questions submitted during the chat box, I want to go to some of the questions we received from you during the email registration process. Our first question: is the Center for Ethics only teaching compassionate communication at OHSU, Dr. Toll, or are you communicating with other providers throughout Oregon, especially in rural communities?
We reach out to every corner of our state. For 31 years, we have been to Prineville, to Astoria, to Coos Bay, to Klamath Falls, to Enterprise, to Burns. Thanks to the Kinsman Foundation, we have been in every part of our state, and we partner with people in the communities. They share information, we share information, we teach with them, we take things back, and it helps us teach the next generation. We've emphasized a lot of the new things we've been doing on campus, but this is part of the fabric of the Center for Ethics.
Thank you. Susan, is this compassionate communication training only for doctors, only for MDs?
Well, when we've talked about how we've been testing the medical students, that's gotten a lot of attention, and it is innovative. And over 3 years, we have developed curriculum, and we test them all as a graduation requirement. But we teach disciplines of medicine, nursing, the social workers, chaplains. When we go out all over the state, there isn't a leading group represented. We have so many people from so many healthcare backgrounds. And we're still building new ways of teaching other groups. Dr. Lynn Jansen, the Madeline Brill Nelson Chair in Ethics Education, launched a new curriculum in partnership with the School of Pharmacy in April, right in the middle of all of the pandemic challenges, not to be slowed down by any of the need for virtual, to train our pharmacy students. They don't need communication skills about talking to patients very much. Their reviews are very positive, but they have been too easily intimidated when they approach physicians, and patient safety is at stake. They know when one drug is interacting with another drug, and they may be very worried that is what's making a patient sick. And if they reach out to a physician and get brushed off, they have not always stood up when they needed to, owned their professionalism, and pushed back. And that's what this session was about, was to partner with faculty in the School of Pharmacy and teach pharmacy students how to own their professionalism, how to be assertive enough to be heard so that they are more active members of the team and for patient safety.
Wow, that's incredibly important. We received another question. Has do not resuscitate order discussions been broached during COVID-19 for patients who are on respirators?
We have conversations with patients about goals of care throughout all of their illness. There's a lot of talk about respirators and would they have to be rationed, and difficult conversations that have not happened in Oregon, but did happen in Italy. And we talk to patients who are very sick and their families about what they want, what they need, what the goals are throughout the process of all serious illnesses. And now with Dr. Katie Stowers, the Ronald W. Nato Chair, Director in Serious Illness Education, I hope one day a chair, to be quite honest, that we are really making a focus of this really serious illness communication to do it better, to walk the path with patients and families and be more skilled in the most difficult of conversations. So yes, it applies to people who have COVID, but it also applies in many other considerations in the face of serious illness. And it's an area where we are very committed to doing a better job.
Thank you. Well, this leads us perfectly into another question that was submitted. How should a healthcare professional answer the question of a healthy patient who is afraid of contracting COVID-19 about whether or not they should have a pulse to align with their advance directive? What do you think about that?
There has been a lot more interest in advanced care planning in COVID. People are talking about what they want and don't want. But there is a challenge of people jumping too far ahead. They're healthy. They would want everything done now if something happened to them. But if they ended up being very, very sick and in that group that's not doing well for a long time on a ventilator, they would want their treatment stopped. That's an advance directive because they are talking about the future if something bad happens. They're not talking about tonight and I'm suddenly collapsing and I do or do not want to go to the intensive care unit to have CPR. Some people have gotten so excited about the Pulse program, and I'm glad it is very loved, but sometimes it's overly loved, to be very honest. And people try to use it for things that it can't do when they're too healthy. And they try to have it serve a future need. It only can serve a present need. I'm setting these limits no matter what now in my current state of health. And if I'm saying if, advance directive, not pulsed.
Okay. That makes a lot of sense. This is a challenging question, but what is the best way to discuss the pandemic with small children under the age of 10?
That's a huge challenge, and it matters where you are as far as the context of this conversation. If a child has a loved one in the intensive care unit with COVID and may be dying, then we want Child Life and experts to be helping just as any other end-of-life, serious illness, likely not to survive situation. Mm-hmm. If, on the other hand, this is like so many children now being told they need to wear masks, that they need to wash their hands more often, that they see masks on people in their favorite park, and they're wondering what all this means and explaining there are germs and we are protecting you from germs and we're protecting other people from everyone's germs. And that's why we wash our hands more often, and that's why we wear masks when we're out. The challenging thing is not to frighten children or each other beyond what we need to. This is a frightening disease. And if parents are really anxious or grandparents are really anxious, that of course will be hard for children. And so getting the help you need to be able to be pretty centered in having these conversations with kids, of course, is helpful.
Thank you. You mentioned in the conversation with Amanda Ashley that private philanthropy allows you to remain above a conflict of interest. Can you speak more to how important philanthropy is to your work?
The Center for Ethics in Healthcare is probably the best example of the power of private philanthropy because we're 96% funded by gift and grant dollars. And 4% of our money comes from the School of Medicine to teach medical students. We use these gift dollars to hire actors, give continuing education credits, hire staff and faculty to do new teaching, do research and scholarship about cutting-edge ethical issues, and to begin to really move forward in these really challenging times. I am just so grateful for the generosity and so committed to using every dollar to maximize the impact.
Thank you. Dr. Toll, we have time for one last question. What about healthcare do you think the pandemic has permanently changed?
Healthcare will be different after the pandemic. I think it's our job to make sure it's better, that it's more holistic and oriented to the whole person. We saw what it was like when people became very isolated in the early part of the pandemic and did not have visitors. And we focused so much on the physical and so little on all the rest of the uniqueness of the person. We also need to continue to improve our communication skills, not only with patients and families, but with each other in the healthcare team, and support each other in what we are all facing. And we can do this and make healthcare more compassionate, more empowering, and more respectful.
Incredible. Thank you, Dr. Toll, for answering these questions and for your critically important work, especially during this time of crisis. Your commitment is just inspiring, and we are so grateful that you are at OHSU. Well, thank you everyone for joining us. Before we close, I would just be grateful if you would share your feedback on today's live presentation. In the chat box, you should see a link to our very quick 3-minute survey. We will also be emailing out that survey to you. And if you would like to learn how to support Dr. Toll and her faculty in the vitally important work of the Center for Ethics, please share your name and your contact information in the survey. And with that, that concludes our live webinar. Thank you for participating. I hope you have a wonderful day. Stay healthy and stay safe. Thank you.